and thank you for the invitation. I'm a professor at the University of São Paulo in Brazil. Are you all seeing my screen?
Yes,
Okay.
very well, thank you.
Yes.
So the foot, as you all know very well, may be the target of several complications due to the diabetes and neuropathy progression. Diabetic neuropathy, as you all know, is generally characterized by distal sensory perception loss, motor dysfunctions, vascular and other autonomic alterations, and all these alterations and losses are commonly associated to plantar ulcerations. Diabetic patients show progressively changes in muscle structure and function, such as reduction of the muscle cross-sectional area, as is shown in this picture, loss of muscle mass and strength, higher protein degradation, slower conduction velocity, loss of motor units, mainly the smaller ones, and process of denervation and reinnervation, as shown in this picture. In this longitudinal study, very well known, structural changes were observed after 9 years in the transverse sectional area of the leg and foot of non-diabetic individuals. However, the changes in the neuropathic patients are much more intense, with greater extent in the foot and greater presence of fat tissue within muscle mass. It is also remarkable the atrophy of the intrinsic foot muscles seen in diabetic patients with neuropathy. We have also observed expressive changes in microstructure as the Z-bands of the muscle, biochemical properties, and mitochondria inner layers. We also have seen differences in fiber density, cross-sectional area, endomysium degeneration, motor units constitution and distribution within the muscle mass, and prevalence and different prevalence of fiber types. And all these changes in the muscle micro and macro structure leads to changes in muscle dynamics. EMG studies have shown improper muscle dynamics when walking. And these are some of the findings that our group has shown in the past years. The vastus lateralis, which is an important impact attenuator, presents a decreased and delayed activation at the heel strike phase. Tibialis anterior, which is also an important decelerator of the foot, has a decreased and delayed foot activation, which compromises the foot lowering phase, increasing the plantar pressure at the forefoot. The gastrocnemius has a decreased and delayed activation at the propulsion phase. And finally, the rectus femoris presents a decreased activity at the end of the stance phase. And they all impair the propulsion of the gait. Besides all these muscle alterations, other joint alterations have been observed, such as loss of mechanical properties of passive tissues leading to foot and ankle or toes deformities, greater joint stiffness, and reduced foot and ankle factors, together will compromise a proper foot rollover during locomotor tasks, which in turn will also compromise the plantar pressure distribution. Among all variables that could be analyzed in the rollover, the peak pressure is the most commonly described parameter in this population and has been consistently associated to plantar ulceration. So the association between muscle dysfunctions and joint alterations will expose the foot to mechanical overloads and consequently to tissue breakdown. So after summarizing this scenario, one might question, what about the treatment and prevention for all those progressive musculoskeletal dysfunctions? Are these dysfunctions targets of any rehabilitation or prevention strategy in a regular basis? Not yet. Considering the official recommendation of the International Diabetes Federation, you need first identify the ulcer risk category of that individual based on his/her risk factors for ulcers. Then, the IDF suggests education and self-management strategies for autonomous healthcare, and depending on the risk classification, there are some preventive strategies that should be adopted. However, in most cases, only therapeutic shoes are recommended for reducing peak pressure. But there are many other risk factors besides peak pressure that should be considered when preventive actions are prescribed. From all those risk factors, at least 4 of them can be prevented by more active actions instead of shoes. Then, having in mind all those musculoskeletal alterations, we should ask ourselves why most of the intervention strategies for this population is only directed toward reducing peak pressure and not targeting the main causes of pressure alterations and foot rollover impairments. Unfortunately, there are still inconclusive results regarding the use of therapeutic shoes for preventing the first episode of ulceration. And we know from 2 excellent trials that there was a reduction in the recurrent ulcer rate only if shoes used were custom-made based on plantar pressure measurements and only if high adherence of the footwear was achieved. In addition, the chronic usage of shoes and foot orthosis, just for prevention for everyone else, may aggravate some of the dysfunctions that I showed you resulting from neuropathy due to movement restrictions. In theory, wearing very structured shoes when not in an imminent risk just for prevention may decrease the awareness of foot position and alter the perception of other afferent information. Keep the foot as a rigid lever and do for your feet what your feet should be doing for themselves, which ultimately ends up weakening them. As our feet become weaker, we need more and more support, and a cycle of dependency is in place. And this can be what happened to people with diabetes that are recommended to use those shoes when not in an imminent risk for ulcer. As a consequence of the cycle, the true potential capacity of the foot to be kept healthy and functional is wasted and felt away. Let's have a closer look to the foot complex structure, whose powerful role we frequently neglect, especially people with diabetes, whose foot is recommended to be always protected as soon as they are diagnosed with diabetes. The foot alone has approximately 26 bones, approximately 25 muscles, 108 ligaments, and 33 joints. And so we have much more structures besides the skin to focus and work with. And we have to keep in mind that all these active and passive structures do not vanish or lose completely their function as soon as an individual is diagnosed with diabetes or with neuropathy. If instead of only focusing on passive solutions for reducing peak pressure, we implement more active strategies for recovering joint range of motion, muscle function, we could improve the foot rollover and redistribute the plantar pressure, which is the ultimate goal when aiming to avoid ulceration. In this paper, we discussed this new paradigm of foot-related exercises for preventing ulcer risk factors. We are not discussing general regular exercises for metabolic control, but specific exercises to recover foot function and avoid further foot complications. The International Working Group on Diabetic Foot published very recently a review summarizing 9 RCTs and 8 uncontrolled studies showing positive outcomes of the foot-related exercises. to improve modifiable risk factors in this population. And I had the honor to be part of this initiative. The positive outcomes were related to improve the foot and ankle range of motion, which is a risk factor, improve the foot strength and function, which is also a risk factor, reduce peak pressures, improve neuropathy symptoms, and reduce the sensitivity loss. So based on these promising results, for the first time, the International Working Group incorporated in the guidelines recently published the foot-related exercises as a strategy to prevent the modifiable risk factors for foot ulceration. We are now concentrating our efforts in developing and validating tools for helping health professionals to improve the management and prevention of diabetes musculoskeletal deficits, diabetes and neuropathy. We follow the contemporary trend of self-monitoring and self-care and developed a booklet. This booklet provides orientation about the disease and self-care and presents a safe exercise guidance for the foot and ankle. It customizes the foot and ankle training based on an effort scale, and it includes 6 simple exercises that progresses accordingly to this rate given by the user. If you're interested, please feel free to contact me if you want to translate and use this booklet in your setting. We also developed a software for monitoring and promoting personalized exercises for the foot and ankle. This is a free and public software, and it's available in English, in Portuguese, and any other language, just using the Google tool for translation. It's available on the web and as a mobile app that can be downloaded in Play Store, just for Android for now. The software development and tests were published in a journal that is open access, and I invited you to read. The software had its content validated by a specialist. Its usability was also validated by users, diabetic patients, and its therapeutic effectiveness is being tested as we speak here in São Paulo. However, the exercises included in the software have their efficacy proven in our previous RCT. So summing up, this new intervention paradigm and the technology resources presented seem to be a way of tailoring the intervention and encouraging the daily habits of performing goal-directed exercises. We strongly encourage the scientific community to carry out high-quality trials to improve the level of evidence of foot and ankle exercises. And we also encourage the health professionals to use the tools developed that are free and have proven their efficacy to prevent and manage diabetes long-term complications. I would like to acknowledge the research agencies for funding our research, and especially to all members of our lab and co-workers overseas. Thank you very much for your attention.